Usually when we talk about a medical diagnosis, there's this underlying expectation of precision. Like, it's almost like engineering.
Oh, absolutely. Like it's a math problem to solve.
Right. If you fall off a bike and break your arm, the x-ray gives you that undeniable, jagged white line. The doctor points at the screen and, well, there it is.
Yeah, it's binary. It's either broken or it's not.
Exactly. And it's comforting in a way, you
It
know?
really is. I mean, we have this fundamental human desire for our ailments to just be visible, to be neatly categorized,
Yeah.
and to have a straightforward mechanical fix.
But then you step into the world of chronic pelvic pain, and that x-ray machine is suddenly just completely useless.
Oh, completely. It's a totally different ballgame.
You find yourself navigating a diagnostic landscape that is, frankly, incredibly murky. So welcome to the deep dive.
Glad to be here.
Today, we're looking at a surprisingly simple plastic device that's being used to navigate that exact darkness. It's treating a condition by literally rewiring how the brain and the pelvic floor talk to each other.
Which is such a fascinating shift in how we think about medicine, right? We're moving away from purely mechanical fixes and really looking at the nervous system's role in chronic conditions.
For sure. So our mission for today's deep dive is unpacking how vaginal dilators are used to treat a specific and often completely unspoken complication of a chronic skin condition. It's called lichen sclerosus.
Yeah, and we're just going to call it LS for short today.
Right, Ellis. And to figure this out for you, the listener, we are pulling from a really comprehensive stack of sources.
It's a big stack this time.
It is. We've got clinical guidelines from dermatologists and gynecologists over in the UK. We have hospital patient leaflets and a bunch of medical abstracts detailing both the conservative and the surgical management of this condition.
It's a lot of ground to cover.
And, when you first hear the word dilator, it sounds so purely mechanical.
It sounds like a plumber's tool.
Yes, like something you'd use to just force a pipe open. But looking through these clinical protocols, it is actually this fascinating tool that treats both the physical architecture of the body and the neurological responses of the pelvic floor, like simultaneously.
Which is just incredible.
Okay, let's unpack this. Before we can really understand the tool, we have to understand the specific problem it's trying to fix, right?
Exactly. To really grasp why a dilator is doing so much heavy lifting, we have to first understand the environment it's being introduced into. We need to look at the architecture of lichen sclerosus itself.
So what does that actually look like?
Well, when we dive into the dermatological guidelines in our sources, they classify LS as a chronic inflammatory skin condition. And the clinical consensus points very strongly to it being an autoimmune disorder.
Meaning the body's immune system basically gets its wires crossed.
Right, it gets confused and just starts aggressively attacking its own perfectly healthy tissues.
Wow. And while it can technically appear anywhere on the body, the sources say it primarily targets the anogenital area, right?
Yeah, that's correct. It's most commonly found on the vulva and the perineum. And physically, it fundamentally alters the whole landscape of the skin.
How so?
It presents with these really intense porcelain white plaques. And depending on the patient, the skin can become unnaturally thin and crinkled, almost like tissue paper, really. Or it can go the completely opposite direction and thicken significantly.
And the main symptom, like the thing that actually drives patients to the doctor in the first place, is this relentless chronic itch.
The itch is severe. It's often what gets them through the clinic door.
But what really jumped out at me from the sources is the structural danger. The real threat to the body's architecture happens when LS is left untreated or if it just stubbornly resists those topical treatments.
Because that chronic inflammation triggers progressive scarring.
Right, and we're not talking about a surface-level cosmetic scar here, like when you scrape your knee.
No, not at all.
The medical abstracts describe how this scarring actively fuses tissues together. You see the labia physically fusing. The clitoris can actually become completely buried under a thick layer of scarred tissue. And most relevant to what we're exploring today, you get severe introital narrowing.
Introital narrowing, or introital stenosis, that's the clinical terminology they use for the shrinking and severe tightening of the vaginal entrance.
And when you read through the gynecological guidelines, the mechanics of this narrowing are just brutal. Because healthy vaginal tissue is designed by nature to expand.
That's its primary function, structurally speaking.
Right. I kept thinking of it like a fresh, flexible elastic band. It stretches to accommodate whatever it needs to, and then it just snaps back to its original shape without taking any damage whatsoever.
Because it relies on collagen and elastin working in perfect harmony.
But the LS scar tissue is entirely different. It's more like a dried out, rigid rubber band that's been sitting in the back of a desk drawer for a decade.
Oh, that's a great analogy.
It,
It's completely lost all its elasticity.
right. So imagine what happens during penetrative sex, or even just during a routine internal medical exam like a cervical smear. When that rigid, unyielding tissue is forced to stretch, it simply doesn't give.
Oh, it tears.
It tears. And it creates these incredibly painful fissures, which are basically open splits in the delicate skin.
And if we connect this to the bigger picture, this exact moment of tearing is where the physical disease metamorphoses into a profound psychological and neurological burden.
Because of the pain.
Exactly. Because think about what happens in the brain when you experience that kind of sudden, sharp tearing in such an incredibly sensitive area. Your body immediately registers immense trauma.
It's like a massive alarm bell going off in the nervous system.
Yes. So what does your body do to protect you from future trauma? Your autonomic nervous system just kicks into high gear.
It panics.
It does. The muscles of the pelvic floor, which form this sort of muscular hammock surrounding the vagina, they involuntarily clench. They go into a state of hypertonicity.
Hypertonicity. So that's like a muscle spasm.
Right. It's a chronic defensive spasm designed to guard against the anticipated pain of the next encounter.
The body is literally bracing for impact, even when there isn't an immediate threat.
And this defensive posturing creates a devastating, self-perpetuating cycle. Let's trace it, right? The lichen sclerosus causes the rigid scarring.
Okay, check.
That scarring tears during penetration, causing severe pain.
Right.
The brain registers the pain and commands the pelvic floor muscles to defensively spasm. And those muscle spasms make the vaginal entrance even tighter and more unyielding.
Man, which guarantees that the very next time penetration is attempted, the pain and the tearing will be exponentially worse.
Exactly. It's a trap.
The body's own defense mechanism is making the original problem worse. And reading through the patient leaflets we have, you can see how this leads to this really deep psychological fear of intimacy.
It's heartbreaking, really.
It leads to the complete avoidance of sex and a massive, measurable drop in a person's overall quality of life. The psychological toll of anticipating that pain is just exhausting.
It fundamentally alters relationships. It alters mental well-being. The patient is trapped between a physical disease modifying their tissue and a nervous system overreacting to protect them.
Which begs the question of intervention. Because if the body is actively building rigid scar tissue and the nervous system is simultaneously clenching the pelvic floor muscles into a tight knot, how do you even begin to reverse that momentum?
It seems impossible at first glance.
It really does. But here's where it gets really interesting. This is where the vaginal dilator enters the clinical picture.
Yes, it becomes a primary, non-pharmacological tool used to physically and neurologically break that cycle.
So what is it exactly?
In its simplest form, a vaginal dilator is a smooth tube-shaped device. They're typically manufactured from medical-grade plastic or silicone, and they come in sets of graduated sizes.
So you get a bunch of them.
Right, a patient will start with one that is very small, sometimes just the diameter of a pinky finger, and slowly work up to larger sizes over time.
And based on the hospital protocols we're looking at, these devices serve 4 very distinct clinical purposes. The first 2 are sort of what you'd intuitively expect, I think.
Mechanical stuff.
Yeah. First, they mechanically keep the vagina open and encourage elasticity in that rigid scar tissue. Second, by starting with the smallest size and gradually sizing up over weeks or months, they help the patient build psychological confidence that penetration is actually physically possible again without tearing.
That mechanical stretching is vital for tissue health, absolutely. But the third and fourth purposes are where the profound healing actually takes place.
Tell me about those.
The third purpose is active retraining of the pelvic floor muscles.
Okay.
You're giving those hypertonic, constantly spasming muscles a physical object to interact with in a controlled setting. You're giving the patient a tool to consciously practice relaxing those muscles around a physical presence.
Ah, I see.
It's about teaching the muscles to lengthen and let go, rather than automatically clenching and guarding.
It's almost like physical therapy for a clenched fist, but internal.
That's a perfect way to describe it.
And the fourth purpose, which really shifted how I viewed this entire treatment, is desensitization. Because the clinical abstracts point out that sometimes the tissues inside and outside the vagina become completely oversensitized to any touch whatsoever.
Yeah.
Because of the chronic inflammation from the LS and the history of pain, the nerves are just misfiring.
And what's fascinating here is how the pain matrix in the brain operates. The brain has associated the genital region so strongly with trauma that it begins misinterpreting safe, non-threatening stimuli as dangerous.
Right. The sources say that just normal washing or wiping with toilet paper can trigger a severe pain response.
It's incredibly debilitating.
So the dilator therapy steps in to teach those nerves that normal touch is safe. You're slowly proving to the brain, through repetition, that an object can enter this space and it doesn't have to result in agony.
Which perfectly illustrates why the dilator is so much more than a mechanical wedge. It is a neurological training device.
Wow.
You're carefully, methodically using controlled exposure therapy to rewrite the brain's hardwired response to insertion. You're taking an autonomic nervous system that screams danger at the slightest pressure and slowly, patiently teaching it to stand down.
And naturally, the sources mention this is often done alongside specialized pelvic floor physiotherapy.
Yes, and the crucial topical steroid treatments that are calming the underlying autoimmune inflammation in the first place.
Right. But I want to pivot to a scenario where that conservative approach isn't enough. Because when you dig into the surgical abstracts in our stack, they detail severe cases where that introital narrowing is so extreme that even the smallest dilator physically cannot be inserted.
The tissue is completely fused shut.
Yeah, it's completely fused. In those specific cases, the sources indicate that surgery is required to physically cut and reconstruct the opening. They outline procedures like a perinoplasty or a division of adhesions.
Correct. Surgery is sometimes unavoidable.
But reading through the mechanics of this, I hit what seems like a massive, glaring contradiction in the medical literature.
Oh, what do you spot in the surgical protocols?
Okay, so let's backtrack to the dermatological guidelines we looked at earlier. They explicitly state that friction or physical damage to the skin actually triggers lichen sclerosus to worsen. They call it the Koebner response.
Yes, the Koebner phenomenon. It's a very well-documented occurrence in several inflammatory skin conditions, including psoriasis and LS.
Okay.
Essentially, any trauma to the skin provokes the underlying autoimmune disease to manifest aggressively right at the site of the injury.
Exactly. So if I'm following the logic here, wouldn't a surgical procedure, which is quite literally intentional massive tissue damage done with a scalpel, wouldn't that inherently cause a massive Koebner response?
This raises an important question, and your deductive logic is absolutely spot on.
Because wouldn't the immune system just freak out, cause a massive LS flare-up, and create even thicker, more rigid scarring right where the surgeon just made the incisions?
You've identified the exact paradox that gynecological surgeons face when dealing with lichen sclerosus.
I knew it didn't make sense.
It is the precise reason why surgical intervention for introital narrowing is strictly, universally considered a last resort. Because you are entirely correct, the body's immediate, overwhelming response to those surgical incisions will be to heal by fusing the freshly cut tissue right back together.
Just gluing itself shut again.
Yes, the Koebner response will drive a rapid, aggressive readhesion.
But if the surgeon knows the body is just going to aggressively glue itself back shut, how does the surgery ever succeed? It sounds like a losing battle against the immune system.
It is a losing battle unless the postoperative protocol is treated as a matter of strict, non-negotiable medical necessity.
Okay, so what do they do?
To make the surgery viable, the medical team has to artificially suppress the localized immune response and physically force the tissues to remain separate while they heal.
How do you force the immune system to stand down after a trauma-like surgery? I mean, it's just trying to do its job.
The clinical guidelines dictate a very aggressive pharmacological intervention. Just 48 hours after the surgery, while the incisions are still incredibly fresh, the patient must begin applying ultra-high-potency topical steroids.
Wow.
Specifically, medications like clobetasol propionate directly to the surgical wounds. This massive dose of steroids suppresses the localized Koebner response and forcefully halts that inflammatory cascade we talked about.
Putting ultra-high-potency steroids directly onto fresh surgical incisions. That sounds incredibly intense.
It defies conventional wound healing logic, but for LS, it's mandatory.
Wow.
And then comes the structural component. The patient must begin using vaginal dilators postoperatively.
There it is.
The abstracts state this usually commences about 4 weeks post-op, once the initial fragile wound healing has stabilized. And here, the dilator is no longer just for stretching.
What is it doing then?
It is used as a physical barricade to block the raw walls of the reconstructed vagina from touching each other and fusing back together.
So it's basically acting as a scaffold.
Precisely. It's a structural scaffold. If a patient undergoes this painful, invasive reconstruction and does not adhere strictly to that post-operative dilator regimen, The literature is crystal clear. The surgery is often rendered completely useless.
Oh, man.
The scarring will return, driven by the trauma of the surgery itself, and it is frequently worse than the original narrowing.
That is wild. So in the surgical context, the dilator is a structural necessity to maintain the physical outcome of the operation.
100%.
So knowing how incredibly high the stakes are here, whether a patient is using them conservatively to avoid going under the knife or using them to preserve a surgery they just endured, how are people actually instructed to incorporate this into their daily lives?
It's a big adjustment.
Yeah, because reading these hospital leaflets, it is abundantly clear this isn't like just remembering to pop a pill with breakfast.
Not at all. It requires a significant commitment of time, mental energy, and physical patience. The hospital leaflets don't just hand over the device and wish you luck.
And they give you homework.
Exactly. They outline a very specific protocol to ensure the patient succeeds and, most importantly, doesn't traumatize the tissue further. They usually start with 2 to 3 minute sessions, progressing to 10 to 20 minutes,
And how often are they doing this?
ranging from 3 times a week to daily, depending on the case.
And what strikes me about these instructions isn't just the physical steps, but how much of this protocol is actually about creating an environment of absolute predictability for a highly traumatized nervous system.
That's a great observation.
It's about removing every possible variable that could cause pain. For example, let's look at lubrication. The leaflets are adamant. You can only use water-based lubricants. They specifically point patients toward hypoallergenic brands like YS or Sutil.
This is a critical safety parameter.
Mm.
The tissues affected by lichen sclerosus are already compromised, right? They're thinned out, inflamed, and prone to micro-tearing.
Right.
Many common over-the-counter lubricants are packed with additives like glycerin, parabens, or warming agents.
And the guidelines explicitly forbid those. But why is glycerin such a problem for an LS patient? I mean, it's in almost everything on the drugstore shelf.
It comes down to cellular biology. Glycerin is an osmolar agent. That means it naturally draws water toward itself.
Okay, I'm following.
If you apply a highly osmolar lubricant to healthy, robust vaginal tissue, it might cause mild temporary dryness. But if you apply glycerin to tissue that is already battered by an autoimmune attack and stripped of its natural moisture barrier,
Oh, I see where this is going.
the glycerin literally pulls the water out of the already compromised cells. It dehydrates them on contact.
Ouch.
And the nervous system immediately registers that rapid cellular dehydration as a severe chemical burn.
So the patient thinks they're doing the right thing by using lubrication, but they're accidentally triggering an agonizing burning sensation, which immediately causes the pelvic floor to spasm, ruining the whole dilator session.
Exactly. It backfires completely.
It makes total sense why the clinical guidelines are so rigid about water-based only. They also strictly prohibit petroleum or oil-based lubricants like Vaseline.
Right, because those can degrade the silicone of the dilators. And they can also trap bacteria against the vulnerable skin.
It's all about mitigating risk. Now, the sources also discuss adjuvants, which are additional medical aids used alongside the dilator to make the process tolerable.
Yes, like topical estrogen.
Yeah, they sometimes prescribe that to help plump and rejuvenate the tissues. But the adjuvant that really caught my eye was a 2% lignocaine gel.
Ah, yeah.
It's a topical local anesthetic used to completely numb the pain of insertion. But if you're listening to this and thinking, wait, applying a potent numbing gel right before intimacy sounds like a terrible idea for the partner?
Yeah.
Well, the medical guidelines are actually right there with you.
They absolutely are.
There is a massive bolded warning about this in the leaflets.
The transfer risk, the very practical complication.
Exactly. The protocol dictates that the patient applies the lignocaine 15 to 20 minutes prior to using the dilator or prior to attempting penetrative sex to give it time to actually numb the nerves.
Right, here's a head start.
But, and this is a critical step, you absolutely must wash the lignocaine off entirely right before actual intercourse.
Because if you don't,
If you skip that step, the anesthetic transfers directly to the partner, resulting in what the medical text formally, and rather dryly, refers to as penile numbness.
which really highlights the complex day-to-day realities of managing a chronic condition within the context of a relationship.
It really does. It transforms a spontaneous act of intimacy into a medically timed procedure.
And open, honest communication with a partner becomes just as vital as the medication itself.
And speaking of procedure, The technique for inserting the dilator itself requires a level of physical awareness that most of us just never have to think about. They don't just say, insert it. They emphasize timing the insertion with a deep, slow exhale.
That is a foundational pelvic floor relaxation technique, and it's rooted entirely in anatomy.
How does that work?
Well, your diaphragm, the muscle under your lungs, and your pelvic floor, they move in tandem. When you take a deep inhale, your lungs expand, your diaphragm pushes down, and your pelvic floor actually drops and relaxes to accommodate the pressure.
Okay, that makes sense.
Then, when you exhale, the pelvic floor gently lifts back up.
So why insert on the exhale? Doesn't that mean the muscles are lifting?
It seems counterintuitive, but the act of a long, controlled, slow exhale actively engages the parasympathetic nervous system. That's the rest and digest counterpart to the fight-or-flight response we talked about.
Oh, wow.
By focusing heavily on extending the exhale, the patient is consciously signaling their brain to release that defensive hypertonic muscle clenching we discussed earlier.
You are essentially hacking your own diaphragm to force the pelvic floor to stand down.
Exactly. You're using breathing to override the alarm system.
And the guidelines pair this breathing with very specific body positions. They suggest lying flat on your back with your knees bent and feet flat, perhaps placing pillows under the knees for targeted support,
Right.
or lying on your side with a thick pillow between the legs.
Yes.
They even suggest standing with one foot securely raised on the edge of the bath.
The biomechanical goal of all those positions is identical. You're trying to find an alignment where the muscles of the pelvic floor and the surrounding core are not actively required to hold the body upright or stabilize the pelvis.
Right.
Because if the muscles are engaged in balancing the body, they cannot fully disengage to accept the dilator.
So what does this all mean? When you layer all these highly specific instructions together, the exact osmolarity of the lubricant, the timing of the anesthetics, the biomechanics of the diaphragm, there was one final piece of advice in the hospital leaflet that initially just completely threw me.
What was that?
Nestled among all this dense clinical talk of introital stenosis and lignocaine, the leaflet suggests setting up a quiet, private space. It literally advises the patient to use low lighting, maybe put on some calming music, and perhaps light some candles.
On the surface, it sounds like well-meaning but maybe slightly patronizing romance advice.
Right. I read it and thought, what on earth is this doing in a surgical aftercare document? But when you view it through the lens of everything we've just discussed regarding the nervous system, you realize it isn't romance advice at all.
Not even a little bit.
It is a clinical, physiological necessity.
Absolutely. Because if a patient approaches their daily dilator therapy like it's a stressful chore, or if they're anxious, rushing to finish before the kids wake up, or, anticipating pain, their autonomic nervous system is going to remain locked on high alert.
Yeah.
The pelvic floor will stay clamped shut, basically acting like a brick wall.
And you literally cannot force a plastic dilator into a spasming, hypertonic pelvic floor without causing the exact tearing, trauma, and Koebner response you are desperately trying to heal.
You'll just do more damage.
So the dim lights, the soft music, the candles, they're biological hacks. They are environmental tools used to trick the autonomic nervous system into turning off the fight or flight response so that the actual medicine, the physical stretch of the dilator, can be safely administered.
It's a really profound way to conceptualize it. The patient's environment is intrinsically part of the medical prescription. You just cannot separate the mind's perception of safety from the pelvic floor's physical reality.
So looking back at the landscape of this deep dive, it is incredibly clear that lichen sclerosus is a cruel, relentless condition. It traps patients in this devastating, self-reinforcing cycle where the skin scars, the scarring tears, and the body's own defensive muscle spasms make the narrowing even worse.
It's a brutal loop.
But these vaginal dilators, whether a patient is using them conservatively to gently, methodically stretch the tissue and avoid the operating room, or using them as a vital, non-negotiable structural scaffold to prevent their body from fusing back together after surgery, they offer a real, tangible path forward.
And the vital takeaway for you listening to this is that this deep dive perfectly illustrates why complex, chronic conditions demand a truly multidisciplinary approach to healing.
Yeah, there's no magic bullet.
No. You cannot simply prescribe a high-potency steroid cream to treat the skin and expect the patient's life to just go back to normal. You have to aggressively treat the autoimmune inflammation with the dermatologist, yes.
Step 1.
But you simultaneously have to restore the physical elasticity, address the deep psychological fear of intimacy, and rehabilitate the nervous system through tools like dilators and the expert guidance of a pelvic floor physiotherapist.
You aren't just treating a localized skin plaque.
No, you're treating the entire interconnected ecosystem of the patient's body and mind.
You really are. It's about restoring a person's relationship with their own body. And it leaves me with this final thought for you to ponder as we wrap up today. We've just spent this time exploring how a remarkably simple physical plastic device, when combined with controlled breathing, the right lubrication, and a clinically calm environment, can literally rewire the nervous system's automated response to pain and trauma in the pelvic floor.
It's amazing when you put it like that.
It forces you to wonder what other areas of chronic, debilitating physical pain in our bodies might be resolved, not just by aggressively throwing medication at the symptoms, but by carefully, methodically retraining that complex brain-body connection through controlled exposure and safety signaling.
It really challenges our fundamental understanding of how we perceive and treat chronic pain across the board.
Because maybe our diagnostic landscape isn't supposed to be like reading a clean binary X-ray. Maybe the human body is murky precisely because our minds, our nervous systems, and our physical tissues are tangled up in brilliant, complicated ways we are only just beginning to map out. Thanks for joining us on the Deep Dive.